Thank you, Carlos. So the last time I talked here was on genomics. I know you were all here. You remember everything I said. So now we've moved a little bit beyond that. We're still trying to figure out how to help our patients in terms of their pain. But in the meantime, since a genomic lecture I gave back in 2015 to now, this whole opioid crisis has come in to our realm. And how is it that we have anything to do with it? When I'm saying orthopedic surgeons, obviously I'm not practicing medicine anymore, but I empathize and have been there. And I used to write a lot of pain meds being in the spine practice. So yeah, like Carlos said, this was a team effort. We have, and I'll show you the slide at the end, it's multiple research associates and about 7 or 8 investigators that did a lot to do this. And then we had a fellow, Mike Deppenwolf, who helped develop the protocol. So those are all the people that did it, and we did a study. But in the meantime, what did it mean? I had to kind of figure this out. What does it mean, and how does it fit in? And what little part are we doing potentially to help in this dilemma that we have as orthopedic surgeons, but also the opioid crisis? So I'm going to talk about like 4 things that I'm going to give a study. There have been really 3 different opioid crises or heroin crises since 1990. I'm going to talk about them because they kind of correlate to what the problem is now, geographically especially. I'm going to talk about the history of postoperative pain because that has some bearing on what we're doing as surgeons and how that affects the opioid crisis, the pain management, especially outpatient pain management, the pharmaceutical companies' involvement, and the present opioid crisis and what's the dilemma. Then we're going to talk about our study and our recommendations. So really, if it starts in the compassionate management of pain, and that's the key. We've all been taught that in medical school all the way through. But when I was in med school and graduated internship in 1980, a lot of things started changing, which I'll explain to you. We were told, don't give them too many Tylenol number 3. You know, you're going to get addicted. The patient's going to get addicted. We'll find out how that changed because false information came in. And then there was a new street supply of heroin, which is coming from Mexico, and I'll explain that too. There's a problem with patient satisfaction being the very much important aspect of our pain control, and we'll talk about that also. And finally, there is an increase in outpatient surgery to this day. We're starting to do more and more complicated surgeries that require a lot of medication. How do we monitor the amount of pills that we give patients for these kind of significant assaults on them, such as a total knee? And we'll talk about that. So that's raw opium. And opiates come from that plant, and it kind of gets down into that type of material called the raw opium. There's 3 major alkaloids that come from this. Morphine, which makes heroin. Codeine, which synthesizes into hydrocodone, which is, makes up Vicodin. And then oxycodone, which is the ingredient in OxyContin, but has been around since the 1930s. All of those have fairly simple, semi-synthetic changes to the molecule, but all come from one of those 3, what they call phenanthrenes. The other is the isoquinoline, which mostly do not do a lot of opioid receptor pain control. They're more on vascular side and some other things. But it's an interesting plant that puts out that many molecules that you can use in human medicine. There's the 3 places that it's mostly seen in. This is called the Golden Crescent, and it's mostly Iran and Afghanistan. The Golden Triangle is mostly Burma, but all around that area. And now we have Mexico, somewhat Colombia too. This is a picture from 1900 when it was at its heyday. Opioid or opium was just being baked and caked. This is in Bombay and sent out. And in fact, 41,000 tons of opium was sent out in I think it was 1905. And then it dropped. For various reasons, it dropped. First, there was some regulatory control, but also it was easier to put in, to smuggle something like heroin than it was opium itself. And heroin became easy to synthesize. Initially synthesized in 1870 from just adding these 2 acetyl groups onto morphine. And you can do that in a cooking kind of thing. So this was the first molecule, the first heroin bottle made by Bayer. It was a good medicine, got rid of pain, and also respiratory disease was a big problem back then. The problem was it turns out to be very addictive, as we know. And the first case of addiction following surgery was in 1905. Then there was the invention of the hypodermic needle. The interesting thing about heroin is you can take it in the lungs, sniff it, snort it. That's why it was so great for respiratory disease. Morphine's not like that at all. You have to inject it. But once the injection was for a hypodermic needle for heroin, many people had already used it to get to that point, kind of a gateway to the injection. So that's how heroin has a gateway on its own from different ways of using it down to injection. Still used in Great Britain for pain control. This is in 1920 when the AMA, for the first time, starts to talk about drugs that have been synthesized and now saying, wait a second, we got to control this. That heroin be eliminated from all medicinal preparations and it should not be administered, prescribed, or dispensed, and that the importation, manufacture, and sale of heroin should be prohibited in the United States. So then it started the black market. And this is China white, which was the most common up to about the 90s. Mostly, like I said, the golden triangle, but also the golden crescent. This is white-looking heroin. So up to about the 1990s, it was all coming in that way through South America, but usually the French Connection, all this kind of stuff. Interesting, in 1963, oxycodone, in a journal called California Medicine, I think it was the California Medical Association journal, felt that oxycodone was significantly addictive. It is very similar to morphine in terms of its addiction. It's what's called morphine milligram equivalence is the same as morphine. It has also demonstrated an addiction potential compared to that to morphine. And this component was in when we were writing the triplicates for Percocet and Percodan, that's what oxycodone is. So hydrocodone is in the Vicodin. This is where I grew up. My hometown is Las Vegas, born and raised through there. This is our cruising street called Fremont Street, and it's now the Fremont Experience. And I had a lot of friends in junior high, believe it or not, but by the late 60s, were using or with somebody that were using heroin. And people that went into jail, ripped off 7-Elevens, got shot, all sorts of stuff happened. And why did this happen? It's a small town. It's not your typical small town, but it was a small town. It started to break out into culture because of the drug culture. And it was the early drug culture really in Vegas. It wasn't like the hippies and psychedelics. This was tough stuff. We called them hard guys, and it didn't last that long. But interestingly, the two most famous people, I think, that were in Las Vegas and died of heroin overdoses, a lot of people don't know that Joe Louis, who was just the famous guy during the war, great heavyweight champion, ended up kind of penniless, sitting in a casino, shaking hands, and using heroin. Now, Sonny Liston trained for the Patterson fight in Las Vegas. He had already been taking opioids. And who knows how he ended up with heroin, but he died of a heroin overdose. There's a lot of controversy on how he died. Did he die with a mob or whatever? But there wasn't any controversy in people who lived in Las Vegas who was on heroin. Both Joe and Sonny both lived there at the time. Joe apparently, when he was doing this left hook here, in his first fight against Cassius Clay at the time, his first fight, Muhammad Ali, Cassius Clay was a contender, just kind of threw out his shoulder somehow. And he had been thrown out his shoulder something, so you guys could figure out somehow, the shoulder guys, what actually happened. But he got on more medicines after that. And then he had to train for the next fight, which was the phantom hook. No one knows exactly how he got knocked out in the first first round. So his career was going downhill by then and did die in my senior year in high school in 1970 of a heroin overdose. So that's my experience with heroin early on, and it's always been kind of on the outside, but fairly close too. This is all written in this book. It's a pretty good book about the truth behind the Ali Liston fights. So that brings us to now, 1990s. In my experience, it brings us to the 1990s. When in early 2000s, the first person I heard of dying of an overdose was a kid who went to University High School in valedictorian, or semi-valedictorian, with UC Berkeley, died of a heroin overdose, early 2000s. what was going on. It wasn't happening in inner-city shooting galleries anymore. It was happening on small-town family picnics. What was going on? This is actually a picture of two parents OD'd in a car with their kid in the back. This is what was going on at the time, black tar. I am going to mention this because this does kind of impact what we do. This is really not a big deal on our manuscript. We don't even mention it in the manuscript we're going to submit. But black tar came in recently in the mid-90s through the mid-2000s through Jalisco, which is just north of Puerto Vallarta, and it was very much a franchise. It wasn't the cartels or anything, and they just brought it up to every small town in America. And I know you've heard a lot of this. If you've listened to anything on the news lately, you've heard how it's been exported differently and marketed differently. All the small towns in the East Coast, up in the New Hampshire, Rhode Island, Ohio, West Virginia, it's more people are dying of this than ever. This is a book called Dreamland, if you're interested in this, because he actually ties it to the OxyContin crisis, too. And it's an interesting crisis, because there were some pain management programs being developed in all those areas from unscrupulous pain management doctors, where actually it's $1 per milligram. Initially, it could get you a high, because if you got it, you could get it on the street, you could shoot it up, you could snort it, you could do a lot of things just like heroin. But eventually, 40 milligrams was 40, and they have an 80 milligram tablet too. You can actually buy the black tar much cheaper and keep the OxyContin for your currency. Okay, so that's black tar, OxyContin, kind of a little bit. I'm going to take you back to the 1970s when I was in med school and then started doing my residency. Anybody recognize these guys? I thought maybe I'd get St. Elsewhere's, and that's Denzel right there. And they're compassionate doctors, and they're concerned about their patients and their pain, because we're starting to realize, or we think we realize, that they're not satisfied. So this is an article in 1973 where they looked at the undertreatment of medical inpatients, and this is one of many, initially starting to talk about the chronic pain with cancer, then chronic kind of benign pain, and now talking about pain in the hospital after surgery. And they went around, and these are psychiatrists trying to find which ones of the patients are really screaming. They're going nuts. They must be psychiatrically a problem. The psychiatrist talked to them, found out there was nothing wrong with them, and in virtually every case, it was found that the patient was not being adequately treated with analgesics, and further, the house staff, for various reasons, was hesitant to prescribe more, which kind of was me and everyone else who was the house staff in the 70s and 80s. There was an educational process going on, not just in the residents, but everyone else in practice, that this is important, that we need to, and it's true, it is, we need to find out how much pain our patients have and treat it appropriately. Unfortunately, some things came out in 1980, and this is the most important one. It's a letter in the New England Journal of Medicine, a 5-6 sentence letter that started getting cited from 1990 especially on, and especially 1995 on, as the truth, as the fact that, and this is what they wrote, we conclude that despite widespread use of narcotic drugs in hospitals, the development of addiction is rare in medical patients with no history of addiction. This letter, not a peer review article at all, in the New England Journal of Medicine was cited, which I'll show you, hundreds of times after that. No addiction potential. So the NIH picked this up, and in 1987, they had this consensus development committee. Lots of guys, pain management guys, physical medicine, internal medicine, cancer doctors, all got together and felt that we were not educating our doctors enough, and other reasons why there's a problem with pain. So they came up with these points. Addiction is rare, and this article has no references. More education, more communication, better assessment by physicians, better patient satisfaction, nursing assessment, and guidelines should be developed. This is 1987. At the same time, around the 80s, the first pain management from an anesthesiology point of view in the hospital was developed at the University of Washington, and that was great. I mean, my patient and me were thankful for that. So these are the forces that are starting to move towards what we're in now. This is a man named Mitchell Max. He's an NIH at that time, one of the original guys in 1987. In 1990, he comes up with improving outcomes of analgesic treatment. Is education enough? This is, again, an NIH guy. And he states that the finding that therapeutic use of opiate analgesics rarely results in addiction has been widely publicized for a decade. Now, who is he citing at that point? And he says, reference 20. There's actually, he references the Wisconsin also stating in some of their references that therapeutic use of opiates entail virtually no risk of addiction. This is in 1990. And there it is, Porter and Jick, being referenced in a New England Journal of Medicine article by a NIH guy. What could be more truth? So then we go to 1995. There's a society called the American Pain Society that's formed. This is the president, and he says pain should be a fifth vital sign. Now, he's not the only one that's saying that, but he makes this in his presidential address. And we will seek backing from industry, and this is a foundation that they're developing to make sure that patients understand this. It's a lot for chronic pain, but also it's going into the acute pain arena also. And a lot of these educational programs, which are starting to heat up because of the NIH stuff, education, is being funded by pharmaceutical companies. Janssen, which makes the fentanyl patch. Medtronic, which does a lot of devices for pain, and then also this new company called Purdue Pharma. So the VA is the first one to pick it up. Pain is the fifth vital sign, and it becomes policy. Quality improvement starts to be a big part of what we do in hospitals. JCO is starting to think about this, and the quality improvement guidelines come out for the treatment of acute pain in 1995 too, and published in JAMA. And here's what they feel you need to do. You have a vital sign sheet, you got to add pain intensity, and you got to record it, just like pulse, respiration, and blood pressure, the fifth vital sign. And they also come out in 2000, so now this is 5 years or 5 or 6, about 5 years later. It finally goes through all the bureaucracy, and AMA adopts the fifth vital sign, and JCO makes it a standard. The rights and ethics, assessment of persons with pain, care of persons with pain, education of persons, these are all great values. Continuum of care, that's key, and improvement of organizational performance. So now I'm going to switch to what's happening on the outpatient side. So that's all inpatient. On the outpatient side, outpatient is just growing like crazy, as we all know. New technology, new pharmacology, new facilities. The problem is the patient or the caregiver becomes the monitor of the pain medication that we dump on them. How do they do what we're talking about in the hospitals? And in the 1970s, some of the biggest problems were pain. There's an article in 97 in anesthesia. Pain was 10% of patients returned to the hospital after outpatient surgery. So we know we got a problem. How are we going to help these patients that are going home with pain? Then in 2004, Canadian Journal of Anesthesia, 30% of patients reported severe pain at 24 hours. So here's a problem we have, and we started hearing this a lot. That a small incision, whatever kind of trauma it is, if it's not covered with preemptive medication surrounding that time, preoperatively maybe with some preemptive, and then a multimodal approach, and then pain medicine for sure, not to have them have that initial insult, they will get that nociception start to be magnified, perception increases, suffering increases, now emotional responses occur further and behavior increases, and you get severe suffer. And now you have postoperative pain treated poorly, can initiate chronic pain. We all agree with that. This was an article in Lancet in 1999 that went through the whole thing. So in the JBJS in 2000 had, which is interesting, an arthroscopic surgery pain protocol. Pain management in patients who undergo outpatient arthroscopic surgery of the knee. And interesting, they put in this, a controlled release formulation of OxyContin, they got Purdue, maintains the therapeutic opioid concentrations for a more prolonged period, thus providing sustained pain relief. And they don't really reference anything in this because it's kind of like well known now. It's going to be a great medication. Here are the citations of that Porter and Jick article or letter from the JBJS, published in the New England Journal of Medicine in 2016, which now has disavowed that letter. And they're saying that letter started the problem. This is how many citations, that's the article. This is how many citations we had of the Porter and Jick. The dark green are affirmative. The light green is negational, they call it, and the white is other. So I don't have an opinion. You can see the dark green picking up in 1990 when all of this performance improvement, NIH, patient satisfaction is starting to pick up. There's no addiction. And then when OxyContin and also the fifth vital sign becomes big in 1995, more articles are being cited. You can see the biggest one is 1996. And then in 2016, we don't have much. It's negational. Actually, the white is actually, they don't have an opinion. And finally, in 2017, all articles are negational, according to the New England Journal of Medicine. No one is saying that letter that we're citing has anything to do with proving that opioids are non-addictive after surgery, acute pain, or anything. So, we're being hit as orthopedic surgeons by multiple things. And one of the things we're being hit by, the mandates, is a mandate of education in 2002. We're supposed to get it done by 2006. All of this was 12 hours of mandatory continuing education on pain management, and all of it was funded by pharmaceutical companies or medical device companies involved with pain management. It was great education. We had to do it anyway. We'd get a good course, but very important part of the marketing. So here's the increased opioid prescriptions. Since 1996, you can see it start going up, which is great for the pharmaceutical companies and for many patients that need it. The problem is we don't know how many patients need it. And this is what happened with the billions of dollars that OxyContin brought to the Purdue Pharma Company. We had many philanthropic donations. This is the Sackler company. Sackler's, the Purdue company is used to be owned by three doctors that are all passed away. There were three brothers, Sacklers. They donated this to the Guggenheim. They donated this to the Smithsonian. They donated this to Harvard, and it goes on and on and on. I'm just showing you some. Some of this is you'll definitely know. They're very much into Egyptians, archaeology. And finally, the one at the Met is amazing. All that stuff donated, billions of dollars made, though. So from OxyContin. In 2007, they were convicted of a crime. This is not just some violation or civil case or anything like that. 1996, marketed OxyContin, $99 billion revenue. 2001, dropped its marketing because they voluntarily dropped its marketing because of all the people saying, well, this has got to be addictive. Now they're starting to find out. But they were convicted of fraud. After billions of dollars, they had a $600 million fine. These three guys, the chief attorney, the CMO, and the president, paid $30 million. I don't think they went to jail either. And Purdue continues on. That's the first pharmaceutical. There's been some others lately. So that's what's happened with OxyContin. That starts to get dropped mid-2000s. So this is the third opioid epidemic. 2010, orthopedic surgeons were told we're 7.7%. So we're not this huge part. Family practice, a lot of other people order a lot more opioids. But we give a lot at once for most patients are what we call opioid naive at the time. There's a flood of opioids and deaths in the New England Journal of Medicine. We're starting to hear all this stuff now in articles and also in the lay press. This is SAMHSA, which is collects data on opioid deaths, which I'll show you. The JAOS had an article, and the AAOS came out with an information sheet that we're supposed to do something. And what it was supposedly is figure out how to do this. But everybody's telling us as doctors, and specifically orthopedic surgeons, figure it out. So this is the deaths up to 2007. And in 1997, there was 3 per 100,000. This is opioid deaths, unintentional, all comers. And by 2007, it had gone up 3 times. It's gone up to 9. So at that point, they started looking at what was the cause. Look at heroin has actually not gone up. This is the OxyContin that's being used, abused, shot, snorted, whatever. But the OxyContin gets too expensive, as we know. So it changes later, but right now, this is what's causing the opioid deaths. In 2013, we started noticing, or SAMHSA started noticing, again, I'm just new to this. I didn't notice any of it, but associations of non-medical reliever use and initiation of heroin use. The initiation of heroin use back in the 60s when Sonny Liston had it, he probably had an initiation with the opioids. I don't know about Joe Louis. No one knows exactly how he got it. But most people, about 80% of the people, or say 20%, had some kind of opioid to be the initiator. Most people used heroin as snorting it, whatever, to initiate it. There was no opioids involved. Now it's about 80% initial heroin users have already used opioids. And they call this NMPR, non-medical pain relief, non-medical use of pain relief, or non-medical use of opioids, prescription opioids. So in this article in 2013, they said this nationally representative study finds a strong association between the prior non-medical use. 79.5% new heroin users have used what they call NMPR, which is non-medical use of pain relievers. So that started to change things. They call it a gateway theory, just like for other things that lead up to injecting heroin. I call it the Sonny Liston phenomenon, but I just found that out from that book. So the relationship between non-medical use has gone even further, because now we're up to 2014, and you can see the prescription opioids haven't even gone up that much. They're probably still initiating some of the problem, but they're not killing any more people than they did. But heroin started going up, and that's because of the black tar being cheap, relatively, and you can pay for it with other meds, like opioids, including OxyContin. Now, this is the latest, and if you've seen some shows, some people have seen the Netflix show. This is a pretty good show on fentanyl, and I'll talk about that because this is the latest perp walk. This is Insys, which is a company that makes this sublingual. You just kind of spray it onto your tongue. It's micrograms of fentanyl, and it's supposed to be for only breakthrough cancer pain. But one time, during the time of development, this doctor gets paid for giving lectures, and the amount of lectures he gets to give is dependent on how much medication he orders. And there's a lot of fraud stuff. He's changing his charts and on, and he happens to be a professor at Brown University Medical School. So he goes to jail for 4 years, about a month ago. He's been recently indicted. There's many, many people that have been indicted. It's just all over again. Did they not know that the 90s got rid of that kind of thing? You know, paying somebody to say promotional materials that are off-label, meaning it's not, they're not talking about breakthrough pain and cancer. They're talking about other reasons. And the insurance companies are paying it for other reasons, and it's on and on and on. And they go public in 2013. And this guy, his name is John Kapoor, got on a TV, CNBC or something, and said, we made $300 million last year. And everybody's trying to do the math. $300 million on breakthrough pain in cancer. Wait a second. So he has been arrested in December 2017. It's an interesting case to follow, but it's part of that, a little bit part of that Netflix show on fentanyl. So now we're going to start to do some healthy changes. What we're going to do is James Campbell, the same guy that wrote about the fifth vital sign back in 1995, he kind of takes it back, but not quite. He kind of takes it back in 2016 on a journal called Pain Journal Online. The editorial of New England Journal of Medicine definitely takes back the letter, and they say that 608 articles, and that's where I got that slide, cited since 1986, 72% stated that opioids were not addictive. We're going to pull that journal. You're not going to be able to find it. Actually, you still can't find it. Then the JCO removed the fifth vital sign. You don't have to do it anymore. You got to be cognizant of their pain, but let's not make a fifth vital sign. And the AMA removed it in 2017. You notice it's only a year ago. Everything's changed in 1 year. Well, one question remained. How much pain medication should I order? We still didn't know. So that's when we started this. There's two problems for orthopedic surgeons, I think. One I've already talked about, chronic pain. You don't want to have the patient where you made the one little arthroscopic surgery. She has RSD chronically for the rest of her life. However that is caused, we're not sure exactly. We don't want chronic pain in our population of patients. But we also don't want opioid abuse, and there's two different types of opioid abuse. One is persistent opioids, and we'll talk about that later after the total knee study, I'm thinking. But for arthroscopic surgery and other kind of minimal surgery, potentially even hip arthroplasty these days, there is a problem with non-medical use of opioids. And that's not just the patient. In fact, that isn't the patient. They're not taking the medicine. It's the community around the patient. So it's a risk for the community. So how much pain medication is needed? We started this thing, we called it the Pain Journal Study. Everybody's heard about it so much that Pain Journal, but we had a great research assistant team who consented patients and just gave them a journal and asked them, how much did you take? How much medication did you take after your arthroscopic surgery? And we were initially thinking, we don't know how much they're going to take, so let's enroll this for 500 patients. There were 8 HOI surgeons involved, and it was all standard of care. This is an outpatient performance improvement project. And if we find something that in an incremental way might be able to improve patient care, then we don't continue on with the study to find all sorts of other things. Ethically, you have to change it. You have to stop and change it. So that's the Pain Journal. And the demographics were typical, 45 females, 58 males, because what happened is we had to stop it at 102 patients. Because it was 500 patients, 102, we did a preliminary review, and we found a lot more meds out there. The total medications that were prescribed were 3,765. Tramadol, I was thinking, is probably okay. We looked at tramadol and all the other opioids we call it, but actually tramadol is a significant opioid. And I initially thought it was what's called a non-narcotic opioid, meaning it doesn't cause you to be high. It's really hard to figure out from all the different people, and I'm talking to the experts. Opiates are the alkaloids inside opium. Opioids are anything that binds to the opioid receptor. And narcotic is more of a law enforcement term. But they were calling tramadol non-narcotic. It turns out Ohio and other states have now put that on the list, just like codeine, just like Vicodin. So it may not be the greatest, but we did look at it. And it's not as addictive, definitely not as addictive as hydrocodone or oxycodone. So this is what we prescribed, all the different medications that were prescribed. Most of it was hydrocodone, Vicodin, or that type of medicine. And then there was, like I said, the tramadol and codeine and oxycodone. Oxycodone, Percocet, or Percodan. So in the results that 102 patients have gone by, there were 3,191 pills, which you can use a scheme where you can say, what's the morphine milligram equivalence? And that's the way they like to have in publications. But let's just say there was a lot of pills left over after 100 surgeries. So that's when we decided we should stop and try to figure out how to improve this process. The other results were that it was kind of all over the board with what doctors were ordering, everything from 15 for 5 to 60 for 10 patients. These are post-op pills, same surgery. I mean, Ben has asked, they're in a letter back, email back, what about chondroplasty? What about local anesthetic? It didn't seem to correlate. We don't have, the problem is we didn't go to 500 to figure out all the outliers and everything else that might involve their pain response, because we had to stop it with after 100 surgeries with 3,000 pills out there. The average time for most people was just 2 days. And 95% of the patients did not use it after 6 days, 95%. This is 62 patients used between 0 and 5, and 28% of the patients didn't use anything. Tramadol, like I said, Australia seems to like it. That's the one place that are geographically around here that does. A lot of the United States are not liking it, but Australia said there is a problem with this enzyme, and you got to figure that out. So if you want to depend on tramadol, I just found this out recently. We may want to go back to genomics again, which I don't think is figured out that well yet. So in the outliers, we had 3 outliers, and Camille was and others were very, persistent on trying to find it. You can get on the Cures website and try to figure out where they had medications from others. And there's some unusual qualities to these patients in terms of their pre-op assessment and some other things that might have led to us thinking that they might have taken a little more, but nothing definitive. And so, again, a larger study would be necessary if we're going to figure out what's going to be the correct screening tools. Although screening is recommended that anxiety or depression and being treated for that, they might have, and these are all obvious and they're written up. There's an opioid risk tool that you go online, and some of these things we're trying to figure out instead of just trying to do the studies and find out other reasons for the outliers. There are already some out there. And genomics, potentially. So the key is there are 102 surgeries, 3,191 pills made available for non-medical use, and it's unclear if anyone properly discarded them. So persistent opioid use, first-time users has been documented. We have some recent articles and other articles. This is a total knee paper done in arthroplasty back in 2017. And it's about 40% of the patients with total knees are going to have persistent opioids, according to them. So we do know it's going to be a problem for those patients, and it's a different problem. They're not going, the definition of persistent opioids is that they're on it for 3 months after a surgery, and they've been opioid naive prior. And what other doctors have they gone to for their other problems also? These are all kind of issues that lead into this. But that's a different problem than the unused opioids. The unused opioids coming to JBJS, the excess opioid in the north, like in New Hampshire area, they just documented there's a lot of difference in what prescribing patterns are of different doctors. No recommendations on what to do with their practices, though, from this data. So what do we learn? We know that heroin is on its upswing, but fentanyl is coming in and lacing it and doing some other problems. But we also know that prescription opioids seems to be a problem for anybody who's on the way. It's about 3 to 4% of patients who end up on heroin who have been dependent on opioids. It's not huge, but that's enough that is concerning. And this is how they get their medication. From one doctor, 22% of them. From friends or relatives, about 50%. And then there's others. They bought it on the street. They're not getting it from their paying doctor. They're getting it on the street from other people. And it's the unused opioids that we're concerned about. This is a pretty good pamphlet from the Orange County Health Department or something. I can't remember the exact name. They came out with a pretty good list looking at all the opioid deaths in 2017 in Orange County. It's like big, going up. And it's interesting, it's the beach cities, the highest. You can see 9.7 to 13.7 out of 100,000. You saw one of those other charts that I had, it went from 3 to 9, and that was a big deal. Now it's 13.7 potentially in some of these cities. And the South County had the highest change in 1 year, 21%. So Take Back Day, turns out this is a DEA, a federal government thing. Everybody's trying to figure out what to do with these unused opioids. When we finished the data, we're trying to talk to the Orange County Health Department, and they didn't quite have it together. You could go to this click and this link and this agency. No one figured it out. Still, Take Back Day would seem to be the only thing because it's a law enforcement problem. It's the DEA that does this, and we just missed it. April 28th, 2018. But we're working on it, and it's going to be another one in the fall. But there are much better ways now that I just found out. And, Orange County Health Department doesn't let us know these things. You just got to go to the website. Oh, one other thing is the FDA said there's been this environmental problem. Don't flush your stuff down the toilet. When my dad died, I had the hospice came in, and, they were getting rid of all his medications, and It was just, it was cancer related. It was for a long time. We had it for a year. All these medications, we just flushed it down the toilet. This was in 2014. And the hospice people made me witness it and then sign something. I still can't figure out what that was because there's nothing about that on any website that I see. The environmentalists are concerned about how much medication is being flushed. The the FDA came out. They did some environmental studies. It didn't satisfy everybody, and not every state, and not every county. But they say the problem with that is so minuscule compared to the problem with unused opioids. Please flush them down if you have no other way. But this is a new way that I just found last night on the Orange County Health. They do have all of these: Aliso Viejo, Anaheim, Buena Park, Costa Mesa, Dana Point, on and on and on. And these are drop boxes that people can drop off, I'm pretty sure, but not absolutely certain, opioids too, except for fentanyl. I don't think you can do that, but I'm not sure about that one either. So I think all of these different local agencies and federal government and state are trying to figure it out. But we got to come up with something to tell the patients. And this is a little calculation I did. I did this last night. It was a much better slide, and then I didn't push save. But I did it this morning again. In 2010, and this was an article I found, I didn't talk about it, but it was an increase in arthroscopic surgery from 2006 to 2010 to 759,000 outpatient arthroscopic surgeries done per year in 2010. If we had 100 surgeries, there'd be 3,000 unused opioids. If you look around the country, and you just get the calculations, there's 22,770,000 unused pills. At this point, I had a really nice slide that comes out with some guy sitting on top of a pile of pills. But just think of it that way. There's going to have to be a lot of drop boxes around. But these pills are still around. They're in everybody's medicine case and drawers and whatever. And so that's one of the things we're going to have to figure out and help our patients and educate them. So these are the 5 or 6 things that we've come up with, recommendations. It looks like 15 opioid pills is the first standard deviation, 68%, will cover patients. If we want to go beyond that, you go to 20 or at 95%. And these are all things that we were hoping that all practices in sports medicine and arthroscopic surgery would kind of come on to agreeing, so they all agreed that we would do this as a unit. Then there's pre-op education, and we have some interns from UCI working on some manuscripts and materials and things like that everybody we were hoping would kind of adopt into their practice. Talking about the potential for addiction, because they obviously know, but this is something else, telling them the side effects, the care of meds, and then discarding of the unused meds. We're going to have to talk about that. We're going to restudy these patients and try after these performance improvements, then we would like to see how many unused opioids after that. And hopefully it's a lot less. And we're going to attempt to detect outliers. We're doing it in a larger study, which would probably be a study that requires medication more often, which is the total needs. We could be able to get the outliers, I think. And we do the 500, much bigger power. We won't have to change it, I don't think we're going to have to stop the study because there's a lot of unused opioids. We're also going to investigate the potential use of tramadol. We need to do some more research on that. But it is less addictive, but it isn't benign. And then other studies are needed, which we are now ongoing, the total knee, and involved with, they're the same. It's an arthroplasty study looking at total knees and total hips as 2 different cohorts. Standard of care, how often do they take their medication? They're bringing those pain journals in, and we're going to see how much they took. We're also going to try to follow them in cures, and there's some, because we know that there's that JBJS article said 40% chance. That was really high. I'm not sure if that's the case, but it'll be interesting to find out. And Jay is back there. Just can't wait to hear, I'm sure, how much medication you're supposed to order your total knee patient. So I want to just thank everybody. This is all the investigators. Carlos and I are not investigators. Well, Carlos was on this one, yes. Still out of practice. He was an investigator. Thank you very much for being involved. Not just there was a lot of work that went into this, the protocol development and all the discussion, and then what we're going to do, and on and on and on. As you all know, this has been on a lot of people's minds. We're thankful that we could finally finish it. There's a research team that also needs to be thanked. Camille, is finishing her final day today, as you all know, and she was a big part of this study. Mary Claire, Teddy, everybody that is involved in this study, we just thank you. And we finally got it done. We're going to submit the manuscript either today or maybe next week or sometime early. So I'm just asking if there are any questions.